Did you know that nearly half of the patients referred to specialists for severe constipation are actually misdiagnosed because doctors skip the basics and jump straight to heavy laxatives? Hello everyone, I'm Dr. X. Welcome back to the channel where we bridge the gap between medical textbooks and real-world practice. Today I am going to give you the ultimate roadmap, the exact constipation algorithm I use to catch cancers, diagnose hidden muscular disorders, and treat the patients that everyone else gave up on. I have my chief resident, Dr. Matthew, here with me to break this down. Matthew, let's start with the biggest mistake doctors make. Which brings us directly to step 1 on our chart, the initial assessment and safety net, because before we even think about treatment, we have to look at the patient's history to find the silent causes. We need to immediately check the medication list for offenders like opioids, calcium channel blockers like verapamil, or even simple iron supplements that stop the gut. And simultaneously we must review their metabolic labs to rule out hypothyroidism and hypercalcemia, because if you don't fix those underlying issues, no amount of laxatives will ever solve the problem.
That is exactly right, Dr. X, and once we have cleared those secondary causes, we have to look at the bottom of step 1 for the alarm features, which are the red flags that stop us in our tracks. We are looking for patients over the age of 50 with new-onset constipation, anyone with rectal bleeding or heme-positive stool, unintentional weight loss, or a family history of colon cancer. If we see any of these signs, we move immediately to step 2, which is our decision point. Because at this stage we are no longer managing simple constipation, we are ruling out malignancy, and that means we must perform a structural evaluation with a colonoscopy to ensure there isn't a mass or stricture blocking the colon.
But let's say the patient is young, healthy, and has absolutely no red flags. Does that mean we just hand them a prescription? Absolutely not, because this leads us to the second part of step 2, which is the mandatory digital rectal exam or DRE. I cannot stress this enough. You must perform a physical exam not just to check for impaction, but to screen for dyssynergia. I ask the patient to bear down and push against my finger, and if I feel the sphincter tighten instead of relax, I have diagnosed a mechanical outlet problem right there in the office, which saves the patient years of frustration. However, if the exam is normal, we can finally move to step 3, which is empiric medical therapy.
For step 3, we follow a strict logical progression starting with the basics. We always begin with lifestyle modifications, including increasing fiber to 25 grams per day alongside better hydration and exercise. And if that is insufficient, we step up to the first line of pharmacotherapy, which are osmotic laxatives like polyethylene glycol or lactulose, because they safely pull water into the bowel. If the patient is still struggling, we advance to the second line, which are stimulant laxatives like senna or bisacodyl to trigger motility. And for our most difficult cases, we consider the third-line agents, the secretagogues like linaclotide, especially if the patient has pain associated with IBS-C.
That is the standard of care. But the real challenge arises when a patient returns 8 weeks later saying they took all the pills and they are still bloated and miserable. Which brings us to the most critical part of this video, step 4, specialized functional testing. We have to stop guessing and start measuring. So we begin with test A, which is anorectal manometry and the balloon expulsion test. This test is designed to evaluate the anorectal angle and pressures to see if the problem is a locked door at the outlet.
And the results of test A are crucial, because if the patient cannot expel the balloon or shows paradoxical pressures, we diagnose a defecatory disorder. The key clinical pearl here is that laxatives do not fix this mechanical issue. And in fact, they often make the bloating worse, so the correct treatment is not more pills but rather biofeedback therapy to retrain the pelvic floor muscles to relax appropriately.
Precisely, but if the manometry is normal and the door is open, we proceed to test B, the colonic transit study using SITS markers to check the engine itself. We have the patient swallow a capsule with radio-opaque markers and X-ray them 5 days later, and this gives us 2 distinct scenarios. If the markers are scattered all over the colon, we diagnose slow transit constipation, meaning the colon is paralyzed and needs aggressive prokinetics. But if the markers are gone and the patient still feels constipated, We diagnose normal transit constipation, which is usually IBS-C or functional heartburn, meaning the problem is visceral hypersensitivity that requires nerve modulators instead of laxatives. That covers the entire algorithm from start to finish. If you found this breakdown helpful, please smash that like button, make sure to subscribe so you don't miss our next case review, and check out our other videos popping up on the screen right now for more high-yield medical content. I'm DriveX. This is Dr.